Good afternoon, everyone. Thank you for joining us. My name is Lawrence Smith. I am the Executive Vice President and Physician-in-Chief at Northwell Health and Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. I also chair the Roundtable on Health Literacy, a project of the National Academies of Sciences, Engineering, and Medicine. I would like to welcome you all to today's webinar, COVID-19 and Oral Healthcare, Implications for Provider and Public Health Literacy, which is hosted by the Roundtable. This webinar will explore approaches to increase the literacy of providers in safer practices in clinical dental care during the COVID-19 pandemic. The Roundtable comprises health literacy experts from healthcare, pharma, community-based organizations, and other fields. We typically host 2 to 3 workshops per year, convening to share promising and best practices and cutting-edge research in health literacy around a specific topic or issue. Recently, the Roundtable has held workshops on integrating oral and primary care through health literacy practices and developing health literacy skills in youth. This June, we convened a webinar on health literacy strategies for reducing COVID disparities among communities of color. Later this month, we will host a webinar on addressing health misinformation through health literacy practices using COVID as a case study. Some housekeeping. This webinar is being recorded and will be archived at the Roundtable website, nationalacademies.org/healthliteracyrt. I would now like to introduce the moderator of this webinar. We are incredibly fortunate to have Dr. Nicole Holland moderate this discussion. Dr. Holland is an assistant professor and director of health communications, education, and promotion at Tufts University School of Dental Medicine. She developed the Tufts Dental School Health Literacy Intensive, a curriculum for health literacy in dental education. Her research interests include the intersection of health literacy, language access, and oral health, as well as the impact of oral health messaging in the media. Dr. Holland is co-chair of the American Dental Association's National Advisory Committee on Health Literacy and Dentistry, and she serves on the National Academies of Science, Engineering, and Medicine's Roundtable on Health Literacy. Dr. Holland is a diplomat of the American Board of Orofacial Pain. She completed her Doctorate of Dental Surgery at New York University College of Dentistry, Master of Science in Health Communications at Tufts University School of Medicine, and Orofacial Pain and Temporomandibular Disorders Fellowship at Massachusetts General Hospital and Harvard Medical School of Dental Medicine. I turn now to Dr. Holland, who will provide some opening remarks and introduce our speakers.
Thank you, Dr. Smith, for the introduction, and thank you to the Roundtable members and project staff for organizing this webinar on such an important topic today. We know that many of our Roundtable members and their colleagues are pivoting their usual health literacy work to focus on addressing COVID-19. Today, we wanted to highlight some of the work being done in the oral health community and lessons that may be useful to the general healthcare field. We are grateful that so many of you are here today to join us in this conversation. COVID-19 has posed significant challenges to the field of oral health. The emergence of this new infectious disease has brought about unprecedented changes, not only in the ways we practice, but also in the way that we as a society navigate the healthcare system. This pandemic's dynamic nature has created an abundance of new and rapidly evolving data, along with recommendations from scientists, healthcare organizations, and regulatory bodies at local, national, and international levels. The dental profession is inherently and particularly at high risk due to the respiratory nature of virus transmission, in combination with the prevalence of aerosol-generating dental procedures and the close proximity with which many forms of dental treatment occur. While unique occupational characteristics and regional regulations must be considered in all of our respective professions, our hope is that this example of a COVID-19 response by oral health leaders, as put forth in today's webinar, can demonstrate how fundamental health literacy principles can positively impact the ways in which effective and equitable healthcare and services are communicated, accessed, and practiced. With this in mind, the objectives for today's webinar are to highlight the efforts to increase provider literacy on the safe practice of clinical dental care in the era of COVID-19, the collaboration between the California State Department of Public Health and the California Dental Association, to explore the implications of CDC and other regulatory bodies' recommendations on oral health care delivery, to highlight the use of health literacy principles to develop clear and concise resources for providers, and to discuss the impact of COVID-19 on oral health equity and public health literacy. So without further ado, I'd like to welcome and introduce our esteemed panelists. Our first speaker will be Dr. Jay Kumar. Dr. Kumar has served as the State Dental Director in the Center for Healthy Communities at the California Department of Public Health since 2015. Previously, Dr. Kumar was the Director of the Bureau of Dental Health at the New York State Department of Health, where he served in several positions, including Director of Oral Health Surveillance and Research and Director of the New York State Dental Public Health Residency. He also served as an Associate Professor at the University of Albany School of Public Health and was a dentist in private practice from 1980 to 2008. Dr. Kumar is a diplomate of the American Board of Dental Public Health and former president of the American Board of Dental Public Health. He earned a Doctor of Dentistry degree from Bangalore University and a Master of Public Health degree from the Johns Hopkins University Bloomberg School of Public Health. Following Dr. Kumar will be Dr. Lindsay Robinson, who is a board-certified pediatric dentist and has maintained a dental practice in Grass Valley, California since 1996. She received her certificate in pediatric dentistry from the University of Florida and dental degree from the University of Southern California. Dr. Robinson is a past president of the California Society of Pediatric Dentistry and the California Dental Association, also known as the CDA, and she served as chair of the CDA Foundation. She was a member of the American Dental Association Council on Access, Prevention, and Interprofessional Relations for 6 years, and during her tenure served as chair for 2 of those years. Dr. Robinson has served on the National Academies of Sciences, Engineering, and Medicine Roundtable on Health Literacy as an oral health representative since 2013. She has been a guest editor for several issues of the CDA Journal on a variety of topics, including oral health literacy, perinatal oral health, and medical dental integration. Dr. Robinson is also a past member of the ADA Board of Trustees. Last little bit of housekeeping. I would like to, before we start the presentations, I just want to ask all the audience members, if you did not have a chance to submit questions in the Q&A for the registration page upon signing up for the webinar, then please submit on the Q&A box at the bottom of the screen. With that, I will ask Dr. Kumar to begin his presentation. Thank you.
Thank you, Dr. Holland. Thank you, Dr. Smith, for inviting me to participate in this roundtable. We are working with Dr. Robinson, the California Dental Association, and the UCSF Technical Assistance Center on another project to enhance dental teams' communication with patients using health literacy principles. Basic literacy and health literacy are fundamental to putting sound public health guidance into practice and helping providers and consumers follow those recommendations. In this context, it is the procedures and protocols that are adopted on a national, state, and local level that can make it easier for providers and consumers to understand and apply information and services that are connected to their health. Today, I'll talk about some key aspects of the California Department of Public Health guidance document for resuming dental care. I'll not be able to discuss the guidelines in great details, but instead, I'll use a health literacy lens to view these guidelines. Next slide, please. COVID is adversely impacting oral health. In 2018, California published its 10-year state oral health plan. A key objective in our plan is to increase annual dental visits. It's aligned with one of the Healthy People 2020 leading health indicators. And this is to address profound oral health disparities that exist today. A strategy is to enhance dental teams' communication capacity. We are working with the University of Berkeley School of Public Health's Health Action Team to develop a toolkit and training resources for using health literacy principles in dental offices. This COVID pandemic will set us back in achieving oral health equity. Most dental offices will not be able to function at full capacity. School-based programs will not be operational for a long time. Many dental offices, especially those providing care to underserved populations, will find it difficult to manage the economic burden. Next slide, please. In California, because it's such a big state, there is wide geographic variation in the prevalence of COVID-19. The county orders vary, and dental offices have to comply with these local orders. Dental offices know how to comply with bloodborne pathogen standards. There's a requirement that all licensees take continuing education course on infection control every 2 years here in California. But this virus requires transmission-based precautions in addition to standard precautions. So there are new recommendations and standards that dental offices have to comply with. Finally, it's important to partner with professional organizations to disseminate the guidance and provide resources. Next slide, please. So California took aggressive action early on in March and issued the statewide stay-home order. We did not envision that in March 2020, we would be communicating the message to the providers and the public to postpone dental visits. Initially, the message given was that the dental settings are not equipped to provide routine dental care during this time of pandemic because of the high risk of disease transmission, shortage of PPE, and too many unknowns about this virus. Our goal then was to focus on managing dental emergencies and to prevent referrals to hospital emergency departments. This epidemic curve had bent and flattened in California by May. So we issued the guidance to reopen. We wanted to send the message that dentistry can create a safe environment for patients to seek dental care. It requires that dental healthcare personnel comprehend the recommendations, standards, and regulations and implement them. The goal was to create a safe environment for providing dental care and protect dental healthcare personnel. It required making several changes in the office protocol and procedures. To bring back the patients, dental offices should communicate to the patients about the steps they are taking to create this safe environment. Next slide, please. Here we are in July. The number of cases and hospitalizations have gone up in California. We have a modified stay-home order in place in many counties, but dentistry being part of the essential healthcare, it's still open. There are differences across the state in the prevalence of COVID, as well as testing rates, containment capabilities, and hospital capacity. There is variation in local orders depending on community conditions. So in May, for example, San Francisco required testing of all dental patients undergoing aerosol generating procedures, whereas other counties required screening for symptoms. Now San Francisco is strongly recommending testing, but not requiring it. In Los Angeles, aerosol generating procedures are to be avoided to the extent possible. So I'm illustrating here the need for clear communication, which is needed in scheduling patient appointment, training staff to respond to inquiries, and when treatment procedures are modified. Next slide, please. We recognize the importance of providing information in an actionable way. When this information is coming from agencies, different agencies and sources in the form of recommendations, standards, regulations, it helps the provider if all these resources are and recommendations are in one place. We try to pull together all these requirements and we try to avoid inconsistencies. There are several new gadgets like extraoral suction, fogger, ultraviolet radiation, and dentists need to know what's the minimum set of equipment required to meet the standards, especially when the science is not clear. We try to communicate this in our guidance by using the terms must and should. Generally, when dentists hear the word that this is a recommendation, the perception is that this is optional. In this case, the CDC recommendations are in the Cal OSHA standards, which are referenced in the state dental board regulations. California employers are required to establish and implement an injury and illness prevention program to protect employees from workplace hazards, including infectious diseases. Adopting changes to their IIPP is mandatory since COVID-19 is widespread in the community. Employers must implement infection control measures, including applicable and relevant recommendations from the Centers for Disease Control and Prevention, and follow Cal/OSHA standards. Next slide, please. The CDPH guidance emphasizes that dental offices pay particular attention to local orders and local conditions. Dentists should access this information about local orders and COVID statistics on a regular basis, understand it, and take these community conditions into considerations when they provide care. For example, the type of procedures and the precautions depend on some extent to what the community conditions are. Another consideration is the supplies. Dentists must ensure they have adequate PPE supplies. The recommendation is to have at least 2 weeks supply. Dental offices should also make face masks and cloth coverings available to all patients and require their use while in the office. In the NIOSH hierarchy of steps, to minimize risk, the most effective step is screening to rule out COVID-19 status. We recommended a symptom-based strategy. The person who is screening is usually a front desk person in a dental office who needs to be trained properly to ask the right questions. We recommend a testing-based strategy only for symptomatic patients who needed to be seen for emergency conditions. There are many challenges and barriers for using a testing-based strategy in a dental setting. Visual signs for respiratory hygiene, hand hygiene, and cough etiquette are important. Dental offices have to make some modifications, including erecting barriers, especially when some practices are based on the open bay concept. 6 feet physical distance should be maintained all the time. Ensure there is a good ventilation and the air movement. Make sure it's from clean area to less clean. This requires consultation with a HVAC professional, and dental officers also should consider HEPA air filtration unit and the use of upper room ultraviolet germicidal irradiation. Staff should be educated and trained regarding job or task-specific duties on preventing transmission. This includes appropriate use of PPE, respiratory protection, cleaning, and disinfections. Staff should be monitored on a daily basis for symptoms and contact. Next slide, please. Dental health care personnel are considered at very high risk because we deal with aerosols. Even when we are providing preventive services, we use handpieces, air water syringe, and ultrasonic scalers. Dental offices are required to develop a respiratory protection program and adhere to the aerosol transmissible standard. This is a new standard. In addition, they have to enhance engineering controls, work practice controls, and PPE use in addition to implementing cleaning protocols. CDC has provided excellent guidance, very detailed regarding all these aspects, and I would refer you to look at those guidance material. The risk associated with aerosols generated in the dental setting is based on old science, so we need more research in this area. We don't know how well these gadgets used in dentistry work, and we have some excellent equipment to capture aerosols in dental settings. Next slide. We recommended that dental offices prioritize care. When the stay-home order was implemented, many patients were in the middle of treatment. The goal here is to take care of these patients and take care of potential emergencies first. We included preventive care as well because we believe these procedures can be safely provided with minimal aerosol generating procedures and prevent future emergencies. We have developed guidance for providing preventive procedures using hand scaling, toothbrush cleaning, fluoride application, and glass ionomer sealing. Next slide, please. So what did we learn? This was a consensus document. We didn't have the time to conduct surveys, focus groups, and key informed interviews. So one thing we learned is that dentists look for clarity. Mostly, they'll tell me, what am I supposed to do? We tried to bring together all the guidance requirements in one place. The conditions are such that we have to give options. Take, for example, the N95 respirators. It's not available in all sizes and quantities. The dental offices want. Fit testing is a challenge. Level 3 surgical masks are not easy to find. So we have some options, and we have described that in the guidance document. Engaging the dental community in this process was very helpful in providing the clarity and the options, as well as identifying required resources and tools. So there are many challenges and barriers. For example, if an accurate rapid point of care saliva-based test is available for all dental offices that cost less than $10, say, then it substantially reduces the risk of exposure, but it's not available. Dental patients require multiple appointments and therefore will require testing multiple times. These tests are not covered by dental benefit plans and most likely will not be covered by health plans. Finally, our guidance documents are text heavy. It would be easier for dental team members to comply with the recommendations and understand them if we incorporated images and graphics in our resources. Thank you very much.
Thank you, Dr. Kumar, for your very informative presentation. I would now like to turn it over to our next presenter, Dr. Robinson.
Thank you very much. Excuse me. Thank you so much to Dr. Smith, our chair, roundtable chair, and our wonderful roundtable staff for bringing this webinar into fruition. And it really was a pleasure working with Dr. Holland and Dr. Kumar on our collective presentations. Before I begin, I just wanted to make a mention of the California Dental Association 150 new logo. We are celebrating 150 years of existence. We began in 1870. 23 dentists in California came together to form the organization. And now in 2020, we have 27,000 members, which is pretty incredible growth. 1 out of every 7 ADA members is actually a member of CDA. Next slide, please. So here we are. As we all know too well, this country is grappling with an unprecedented public health crisis, which has upended all segments of society and changed the way people go about their daily lives. And it has put tremendous strain on the healthcare system. And as part of that system, it includes the delivery of oral healthcare. And so the goal of my portion of this is to give you a peek into the work that we did at CDA to translate all of that text heavy and the complicated guidance and requirements coming from the regulatory bodies, translate it into documents and resources in a manner that our rank and file dentists could understand and use easily. Next slide, please. So before I dive into that element, I just wanted to give folks an idea of what dental practice is like. And many of you may understand that, but dental practice is really, we practice outside the broader healthcare system. We are generally small business owners in solo or group practice. We're employers of staff. And so we do not have a hospital system or a healthcare system to provide us with the guidance and the delivery of and the PPE necessary to be able to deliver oral healthcare. So it's upon us, it's upon the dentist and the employer to make sure that all the PPE is sufficient to cover services, and that there's enough funding coming into the office to make sure that we can pay all of our staff and cover all the expenses that we need. We also are required to comply with all CDC infection control standards, Cal OSHA guidelines standards, and California Dental Board requirements. Next slide, please. So both Dr. Kumar and Dr. Holland talked about the risk of dental practice, the provision of oral health care, and that's because hygienists, assistants, and dentists are practiced very close to patients. That close proximity is risky, as well as the exposure to dental aerosols. And we'll talk quite a bit more about dental aerosols in a moment. But compared to other occupations, we are the highest risk of all different, of any work, of the workplaces. So let's go to the next slide, please. So I wanted to start by providing you some information on the ADA developed resources. The ADA early on in the pandemic began by creating an ADA COVID-19 advisory task force. And the folks who actually worked on this return to work interim guidance toolkit took health literacy training the previous summer. So the ADA has invested quite a bit of resources and funding into supporting efforts around health literacy and dentistry. And one of those is training their staff on health literacy best principles. And so that guided them in developing this toolkit for dentists to reopen. The other piece on the other side is it's brand new. It came out just a few days, and it's a communication tool for dentists to help their patients understand what it's going to look like going back to practice and going back to the dental office for care. Next slide, please. So about the same time, CDA created their own clinical care work group, and I was part of that work group. And the goal was to actually to use the ADA documents as a foundation, but knowing dentists wanted clarity and concise and clear information and how to understand how to comply with all these new regulations. We wanted to be very granular in what we presented. We also felt it was important to have a public-private partnership. We were very fortunate to have Dr. Kumar as a co-chair of this work group, and he was our voice at the State Public Health Department and with Cal OSHA to make sure that they were releasing guidance in a timely manner and specific to dental practice. We needed our own guidance because we're unique because of the dental aerosol issues. So we had multiple stakeholders who were part of this group. They included the president of the California Dental Hygiene Association, the president of the California Dental Assistants Association. We had a dental director for Federally Qualified Health Center there as well. She's also part of CDA leadership. And we wanted to identify the existing evidence base as a foundation for all of our recommendations. We divided into 3 groups, PPE, aerosol management, and protocols work group. The protocols work group was tasked with taking all of the information from what we were learning about aerosol management, all the evidence, taking all the guidance from CDC and OSHA, and turning that into resources that were easily digestible and based upon health literacy best principles. We also have been using end user testing to inform improvements. Now these documents are pretty new, but we learned early on from phone calls and emails from members that they were having difficulty sifting through on the website all of the resources. There was such a rich amount of resources. So we conducted some testing to understand how to best reorder the website and to make it easier to navigate and find specific resources. And then finally, we wanted to identify the gaps in knowledge. Dr. Kumar mentioned in his presentation about there just isn't a lot we know around quantifying the mitigation of aerosol transmission when we use a combination of different environmental controls. And there are all of these new kind of fancy, somewhat expensive devices being that are out on the market now that are meant to mitigate the aerosols, and we don't know, we just have no idea how well they work. And so early on, digging through the evidence base, it was pretty clear that we needed more research on those devices. Okay, next slide, please. Okay, so this, to give you some idea of the resources, we wanted them to be simple, clear, and easy to follow. So you'll see flow charts, you'll see checklists amongst the training and the resources that we provided. This particular piece is a regulatory reporting requirement. If a patient reports symptoms within 2 days after a dental visit, or if an employee reports symptoms or exposure to a COVID positive person. So this flow chart was actually updated yesterday because updated guidance and requirements came out from OSHA and CDC related to this. So we're constantly needing to update resources based upon the latest guidance, and as we know more about virus transmission and spread. So that also you can see that we used health literacy basics here in the flow chart, white background with pops of color. And again, the goal for us was to take all of that text heavy, complicated information coming out from all the regulatory agencies and convert it into a way that makes sense for our members to use. Let's go to the next slide. So this is a very important piece here. This came out from of the aerosol management group, and I was actually part of that group. First of all, we understood that we need to think about this in terms of zones. Zone 1 is intraoral. Zone 2 is 3 feet surrounding the oral cavity. Zone 3 is the operatory, and Zone 4 is the general office setting. So we put together just a huge amount of resources around looking at the evidence, understanding what kind of environmental controls are needed in each zone, and putting that in a larger document that accompanies this particular diagram. So this you can find on the website, and also the document that demonstrates all the different mitigation efforts for each zone. It also highlights the evidence. We put together a list of resources that came from the literature that you can search and look at, and we also offer some information on untested but interesting types of infection control items like UVC lights, hypochlorous acid as an anti-fogger, as a disinfectant for countertops. They're not EPA approved at this point, but they're important to think about in terms of future research. So next slide, please. So I wanted to share this with you. This is a chart that is helping dentists and hygienists understand the proper PPE based upon the degree to which they're exposed to aerosols. So I have the example, the bottom row is the highest risk, using a handpiece with water spray to do a filling as an example, using a Cavitron or ultrasonic scaler for hygiene is another example. And their PPE required is a fit-tested N95 mask with a caveat, and this is CDC guidance here when N95s are in short supply, which has been the case, that a level 3 mask with a face shield over it is okay to use. Also a face shield just in general, gloves, of course, a gown, head, and shoe covers as well. So let's go on to the next slide, please. Okay, so when N95 masks are in short supply, this is a photograph of my office. There were a few of us who got together from the COVID-19 work group and put together a little subgroup on masks, looking into masks. And one of the alternatives to N95 respirators are reusable elastomerics. And so I decided to purchase them for my office because I couldn't find enough N95s for my office. I bought them from a metal working supply company. They were readily available, and they're pretty easily fit tested. They're reusable. They're disinfectable. There are a lot of pluses. They're just kind of bulky. And they also have an exhalation valve in the front, so you have to wear a face shield in front of it so you're not contaminating the patient, exposing the patient to, the provider's exhalations. So that's what we did. We're also looking at powered air purifying respirators as an alternative. If you can imagine a hygienist in a tight fitting mask for 8 hours constantly, that would get pretty difficult to breathe through and very warm. And so PAPRs are, I think, a viable alternative. And in fact, CDA, there are a few of us at CDA who are working with the Michigan Dental Association to test out a new PAPR device that has been modified for use for dentistry, because we wear loops and a light, and they have to be able to fit over all of the loop material, and they also have to our exhalation has to be on the behind us, not in front of us, and they don't require fit testing, so they just fit over, and they're reusable as well. So next slide, please. Okay. So this document is a high-level flow chart on screening and triage of patients based upon COVID-19 risk. And it's very easy to follow. Again, it's a nice flow chart, and it provides treatment options based upon the symptoms the patient brings in. So if there might be a case where if somebody is COVID symptomatic, you just work with a medical provider and just provide emergency care only. Non-urgent care can be delayed. Sometimes it just using minimally invasive care without using any kind of aerosol generating procedure is possible. Use of silver diamond fluoride is an example, glass ionomers, minimal aerosol transmission with those, in fact, no aerosol transmission with those. So next slide, please. Yeah, this is the This is the continuation of that same workflow document. And I also wanted to give you the website statistics for all of these resources. We launched on May 18th, and from May 18th through July 5th, we had a total number of page views of just over 174,000. We had unique users of almost 116,000 unique users. So remember, these resources are in front of the membership firewall, and they're accessible to everybody. So I think that's why we're having so many people log on and download this material. Most of them are actually outside of California. The top 5 resources were back to practice staff training, and I'll show you that in just a minute. The N95 respirator mask information, patient screening form, respiratory protection program, and the employer screening form. So we have a really wonderful package of for back to practice staff training. And if you Google CDA back to practice, you'll see that you'll see the page, and there are 5 buckets, 5 categories of resources. And so that makes it easier to search for specific types of resources that you're looking for, whether it be PPE or patient protocols, patient care, billing, that kind of thing. And below that is the Back to Practice portal. And if you go on there, you'll click on that, you'll get all the information and all the packages for training of staff. You can also get CE using that material. And again, it's entirely free to the oral health community. There's no fee for that as well. And it's a good day's worth of staff training, and it gets granular as to how the workflow should be, the administrative controls that you need, the environmental controls that you need, screening of patients before they come to the office, the questions that need to be asked, taking temperatures, making sure the staff is screened every single day. All of the forms and documents are needed for doing all of that are included in this package of material. So next slide, please. So I understand that the public health literacy and the issue of oral health equity, there are 2 slides related to those, but we could spend a whole webinar on the impact of this pandemic on oral health equity and how it's really set us back quite a bit, as Dr. Kumar was saying. So public health literacy has been discussed a few times at the roundtable, at our workshops. We've had Dr. Dean Schillinger from UCSF present on that, where he describes the concept of public health literacy as multidimensional in nature, engaging many stakeholders like the public, lawmakers, policymakers, and not just clinicians and patients, to address issues of public health, prevention, and upstream determinants of health to reduce disease and alleviate suffering. And certainly in our case, public health literacy is needed to create a safe dental office environment, which is critical for patients who are seeking dental services and oral health professionals who are providing the care. So as dentists, we need to make sure that our staff is safe and that our patients are safe in the provision of care for them. So case in point was trying to get our public health officials to understand that we need the proper PPE. There were not sufficient N95 masks on the market. You couldn't buy them. And fortunately for us, well, initially the State Department of Public Health in California agreed to give us 1 million N95 masks from the stockpile. And so CDA paid to have them transported from the stockpile to a holding facility to distribute out to dentists in California. The day after we took possession of them, the state asked us to give them back, and they showed up with their trucks to take them back. And so we were back to square one, basically. And so it's been difficult. We've had to advocate for dentistry and for oral health providers to make sure they have proper PPE and that public health folks understand that we are part of the healthcare system. Our risk is higher than anybody else outside the hospital setting. So we deserve and we need those types of supplies. So let's go to the next slide. Oral health equity in the era of COVID-19, and I don't know Dr. Kumar mentioned this, the impact on both dental clinics and dental offices who treat Medicaid patients has been very difficult. Many of them are still closed. Some of you may have seen that Wall Street Journal article that came out a few days ago that almost nearly 2,000 dental clinics that serve minority people of color are closed, and not temporary closed, and not, who knows when they'll be able to reopen. And that primarily impacts people who are underserved and have been underserved in the past. So this is just one step back, one giant step back from where we actually were before. Certainly the effects on all state budgets, California's especially. We've had to advocate to the governor that they maintain the dental Medicaid benefits for adults and the reimbursement levels that came from Prop 56 funds, tobacco tax funds. Initially, those were not in the governor's budget, and we were fortunate enough to have enough advocacy power behind us to get those back into the budget. Also, the governor's new revised budget eliminated expansion of benefits for undocumented adults. So no Medicaid dental care for adults and for undocumented, and that they're really a backbone of the economic engine of California. So that's really unfortunate. And then finally, compliance difficulty with airborne transmission standards relative to the high disease burden of many Medicaid patients. Because they've had such problems with access in the past, they come to the dental office needing a lot of care that requires a lot of periodontal care, dental care, restorative care, and that generates a lot of aerosols. And that's been very concerning, especially in a world where we don't have sufficient PPE to go around for everybody. I just wanted to mention also the work that CDA has done over the last decade around improving the oral health, not just for people who can afford to pay it, but for everybody in California. And that really began with the creation of the Access Plan that came out about 8 years ago. And that plan guided CDA's efforts, advocacy efforts, towards establishing a state office of oral health in California within the public health department. Prior to that, we really had none. We had no Dr. Kumar, we had no epidemiologist, we had very little advocacy at all inside the State Department of Oral Health. And so that access plan guided our efforts to make that happen. And ultimately, it led to us being able to afford to hire, or the state to be able to afford to hire Dr. Kumar, an epidemiologist, a programming officer, and all provide them with the resources they need to make sure that we have a strong voice in state public health for the benefit of all Californians. So next slide, please. With that, thank you. I just wanted to mention that I have the opportunity to guest edit another CDA journal issue on oral health literacy. It's coming out actually next month. There may be some of you who are viewing this who actually contributed as authors, and I thank you very much for your effort and volunteering to do that. I'm very excited about this coming out, and so please look for it online in the next few weeks. With that, I will say thank you very much for this opportunity.
Thank you, Dr. Robinson, for an outstanding presentation. Lots of resources that many are asking about in the Q&A. So I just wanted to remind everyone that all of the CDA materials are open to the public. So certainly you can access all of those. And then also for those asking for the slides, and the recording, it will be posted latest tomorrow. The roundtable at the roundtable website on the nationalacademies.org. Look for the Health Literacy Roundtable. The slides should actually already be there, if I'm correct, Alexis. So both of them should already be there for you. So everything will be made public, both the CDA resources as well as the recording. So to get on to questions, there have been a lot that have come in both before, during registration, as well as currently through the presentations. I'm going to start off the first question, which addresses many of the questions that came through before, which is, and I will direct this to both Dr. Robinson and Dr. Kumar, how are you systematically addressing health inequities in your work? And what is the role of health literacy in this? Dr. Robinson, you did address this a little bit at the end, so we'll go ahead and start with Dr. Kumar, and then of course, if you'd like to respond as well, feel free, please.
Thank you for that excellent question. From a public health agency's perspective, we always look at assessment as a key function. So in this case, identifying oral health disparities and the causes of it, identifying social inequities in access to the resources and opportunities, those are some of the things that we do it routinely. And also to communicate the findings of these assessments in a simple, easy to understand way. Then using this assessment, we create policies and programs. And then evaluation is also very key because we want to identify best practices, promising practices, and build the evidence base, as well as we want to track progress with respect to some of these indicators. And finally, planning the next steps using the information and communicating the findings to stakeholders and partners to reassess these strategies, whether they're working or not, and planning next steps. Those are some of the approaches that we are using to address health inequities.
And I would just add that all of that requires funding and money, and CDA has been really instrumental in making sure there's sufficient funding for activities like that. And just as an example, there was a ballot measure a few years ago to increase the tobacco tax in California. That was Prop 56. And that was a collaborative effort with many of California's dentists in order to get it on the ballot in the first place. And that funding has allowed an increase in reimbursement rates for not only dentists, but for physicians as well in the Medicaid program, and also to fund some health literacy activities for the State Department of Oral Health.
Yeah, I can expand to answer the second part of the question, the role of health literacy. So as I said, we are working to address this. We consider health literacy as an approach to address health inequities. And we are addressing barriers in dental care settings is key. It's important. So we are developing a toolkit and training resources to achieve that. But another part of it is extending this to community settings. I'll give an example. In California, we have a requirement, kindergarten oral health assessment requirement. So what that means is we'll be able to deliver healthy children to school so they don't miss school days because of dental pain. So we are encouraging all our grantees to focus on especially target their efforts to low-income schools and schools where there's large proportion of minority population where there are some barriers to make sure that all kindergarten children are assessed. But it takes a lot of effort, health literacy related efforts, because we have to communicate this to the school boards and get their approval. We have to communicate this to parents. And we have to train champions in order to accomplish all these things. So in all these efforts, we are trying to incorporate health literacy principles. Thank you.
Thank you, Dr. Kumar and Dr. Robinson. If I can just follow up, there were a lot of questions that came in also through the registration page about school-based oral health programs. So what do you see, Dr. Kumar, as the future of school-based oral health programs?
We have some real challenges when it comes to, we don't know, there are a lot of facilities whether schools will open this way. And when they reopen, convincing them to, allow us to provide clinical services in schools is going to be a huge challenge. And so towards that effort, we have actually created a protocol, how clinical preventive services can be provided in schools without generating aerosols. So, and we're also looking at what are some of the alternative ways. For example, school linked the program may be an approach that we can use in the future, where we can screen children, identify them, because most of the schools are used to vision and hearing screening. So this will be very similar to that. And schools probably will be more amenable to allow dental professionals to do the screening referrals. And the important piece of that is linking them to a source of care, tracking it, making sure that children receive the needed services and establishing a dental home for them. So that is another model that can be explored.
And if I just could add to that last point that you made, Dr. Kumar, about, we we have a program that started in California called the Virtual Dental Home Program. That was from UOP. And we've been pretty successful in linking hygienists out in the community, in community settings such as daycare facilities, Head Start facilities, linking them, collecting the data and sending all of that information to a dentist, and having the dentist look at all of the information, and also the judgment of the hygienist on site, and providing some palliative care. I think also there's a great opportunity here to promote minimally invasive procedures like the application of silver diamine fluoride and glass ionomers. And so often as a pediatric dentist, and I use those tools so much, and they become such an important part of what I do. I just really think there's you got to look for the little opportunities in the midst of this pandemic. And I think this might be one of them, is to promote those types of efforts for kids.
Great, thank you. I'm going to switch gears a little bit to think about more of the public health literacy piece, and potentially, there's a lot of questions and concern from the public about re-entering the dental setting. And several questions have come in. So what would you say are the top 1 to 3 messages to convey to patients about getting dental care for themselves or family members in light of COVID-19? How would you encourage providers to engage in this discussion?
Well, if I may just offer again, the resources, both the ADA just came out with that communication tool that's customizable. Now it's brand new, so there's been no end user testing or out in the field, but there is something there, and it's got really nice infographics, and it provides patients and with the information about what they should expect that the dentist should be doing. And also CDA also has quite a bit of information. They have some media, like little resources that you can use, that a dentist can use out in their community to broadcast out to the media, and also their own social media. But I think it's very important that dentists communicate effectively what it's going to look like, what they're doing in order to comply with all the requirements to make sure that patients are safe and their staff is safe.
Great, thank you. Dr. Kumar, I have, and we're almost out of time for questions, but this one is also a theme that has come through regarding provider literacy. There have been a lot of different recommendations that have come out. Essentially, who is the authority on this information? Is it better to follow federal guidelines? Is it better to follow state guidelines? How would you answer that question?
So I try to answer that in one of my slides. We have to comply with all those recommendations, because CDC, OSHA, state guidelines, and local health department ordinances. So they're all important. And what we try to do is bring all of them together in one place. So that's the best way I can answer that question.
Okay, thank you. And my last question for Dr. Robinson, what are the plans to integrate the updates of science in the pandemic into the communication processes and materials moving forward? And has language access, have these been thought to translate into various languages?
So I did check back with CDA staff, and we have to recognize that these are brand new, brand spanking new, and for the most part. So they're only in English now, but we can certainly, especially Spanish, would be the next language. I believe it totally makes sense, especially around patient communication, because so many residents in California don't speak English. They speak other languages, and primarily Spanish. But I think that especially around patient communication tools, that will be an important next step to do that.
Great, thank you. And thank you both again very much, Dr. Kumar, Dr. Robinson, for your wisdom and expertise as it relates to where we are as a dental field, and hopefully all those in healthcare can glean some lessons from what we learned today. So thank you.
Thank you.
Thank you very
I
much.
do want to briefly summarize one of the main points that I heard. Communication. Obviously, we need to think about tailoring the communication to who it is that our audience that we're talking to, whether it be patients, providers, the public health space, the regulatory bodies. A lot of this changing science, we're really going to have to be malleable in how we deal with this. And then also the need for research. There's a lot of need out there. We did briefly discuss funding. Certainly, hopefully we can put some pressure on some funding bodies to have the research come from this. So thank you both. I will now turn it back to Dr. Smith so we can go ahead and conclude the session. And thank you to the audience members for tuning in as well.
Thank you again to our speakers, moderator, and the audience for a wonderful discussion. Thanks also to the National Academies staff for facilitating this webinar. As a reminder, this webinar has been recorded and will be posted on the Roundtable webpage with slides within a week or so. Please sign up for the Roundtable listserv for updates about future webinars and workshops. Take care, everyone, and thank you.
Thank you.
Thank you very much.